Welcome everyone to another Saturday radiology session by Team Radiogyan. Before we move on to today's talk, remember that anything we discuss today and even in our future and previous talks, nothing is considered to be medical advice. This is only for educational purposes. For our viewers who are watching it live, welcome. For those who are watching it later, we'll have links. Links to each section of the video in the description below, so you can jump to the section that you are interested in. Today's speaker is Dr. Ameya Kulkarni, who is a staff radiologist at Judovinsky Hospital and Cancer Center, McMaster University Canada, and he'll be discussing a few body MRI cases. Without wasting any further time, over to you, Ameya.
Hi, Amar. Thanks for the introduction. So today's session will be just a rapid review of some interesting body MR cases, and it's basically a quiz format. So be ready to type in your answers. I'll be giving you some options. You have to choose what option suits the best for each case. So I have split them into three kind of rounds. The first will be slightly easy, second will be moderately difficult, and third will be slightly difficult cases. So I'm pretty sure that especially the residents will find it to be more interesting and engaging, but the staff radiologists who will be attending this session will also find it to be interesting, as there may be some type of cases which are not some of your usual run-of-the-mill cases. So without wasting any further time, let me start sharing my quiz here. So I hope my screen is visible. So you can see there, just an MRI quiz. So let's start. So before we head into the quiz here, just an important thing, no financial disclosures. So round one, as I said, it's easy. So remember that without questions, there is no learning. So especially all the first or second year residents out there, always remember, ask questions. Doesn't matter how silly they feel to you, it's always nice to ask questions because that is how you're going to learn. So case number one. So I have some static images from ultrasound. You can see it on the left side. This is a transvaginal pelvic ultrasound sagittal view, as well as transverse view of what appears to be a right adnexal mass. The lesion looks like it is a predominantly cystic mass, but it also has these echogenic nodules. This is the axial T1 weighted image of the same patient's MRI. And then we also have this sagittal T2. It looks like it is right on both with some internal complex nodules there. And then this is an axial T1 Dixon water, which means that it does not have any fat signal in this case. And this is a comparison CT for the same patient. So take a look at these images and be prepared for the next question. This was the question which I had posted on our Facebook group. So the question here is that, do you feel that this lesion is benign or a malignant lesion? So remember that with all the new ORADs which are coming into place, as well as the IOTA terminology and all those kinds of things, it may be challenging for you to put it into the right ORADs category once in a while. But this question is simple: A, benign, or B, malignant? So I can already see the answers here. So it is benign, yes, and it is, as you pointed out, everyone, it's just a dermoid cyst. So an ultrasound dermoid cyst has typical features. You will see those echogenic nodules. Sometimes if the patient has lots of echogenic low-level echoes or low amplitude echoes within the cyst, and then they can also have mature teratomas, can also have things which are called as Rokitansky-Ashkoff sinuses, which can also have, like, it's also called as dermoid plug, and they can almost have things like tooth or hairs, all kind of things within it. So great for answering this question. So let's move on to another case. Again, some of the easier cases here. So all I have on the left side is an axial post-contrast T1 weighted image of the brain taken at the level of the brainstem. You can see the middle cerebellar peduncles here. And this is a coronal reformat of the same individual. It's taken at the level of both lateral horns of the both lateral ventricles. So take a quick look at these images and then be ready for the question. So pay attention to all the things, the CSF spaces, imaged brain parenchyma, then look at the visualized sinuses, whatever you can see in this image, right? So if you have had a quick look at this image, the question here is that, what is the name of the anatomic variant seen on this image? So go through the options here: petrous apex pneumatosis, Noddy cells, persistent trigeminal artery, or just a vascular loop associated with the 7th, 8th cranial nerve complex. So keep these options in mind. I'll give you a sneak peek into the image once again. Look at this image. This is an axial post-contrast image and a coronal post-contrast image. So look at the options, type in just A, B, C, or D, whatever you feel is the right answer. So I can see the answers. That answers are C. So Eda, Nilanjan, Selda, everyone is giving the right answer. This is just a persistent trigeminal artery. For those of you got right, excellent job. For those who are still trying to wonder where the abnormality is located, make sure that you look at this small enhancing tubular channel here in the pre-pontine cistern, which is nothing but a persistent trigeminal artery. And this is a coronal reformat. On this coronal reformat, you can see that this is the persistent trigeminal artery, which is going anteriorly and correcting to the carotid circulation. So what are these persistent arteries? So these are nothing but the embryonal or embryonal connections between the caroticobasilar system. So this is just a small schematic. You can imagine this to be just like a sagittal view. The artery on the front, the more chunkier one, is all carotid and its branches, and the one behind is the basilar artery. So you can have posterior communicating artery, which is still present in most of the population. Then you can have this persistent trigeminal artery, which we saw right now. You can have a persistent aortic artery, or you can also have a hypoglossal artery or proatlantal artery. All of these are just connecting the posterior circulation to the anterior circulation in embryonal stage, and they subsequently vanish. But in certain individuals, it can persist, as we saw in this case. So with this easy round, round 2 can be moderately challenging. So remember that all big things come from small beginnings. So you have to make sure that you decide to make a small change in your everyday practice. So remember, this is just like a small quote. So with this, let's go to one of the cases on this section here. So I have axial T2 weighted image, axial post-contrast image of the upper chest. So this was not a diagnostic scan centered around the abnormality in question, but anyways, it was picked up. So all you see is that this is the area just below the thoracic inlet. Both are same sections. On T2, you see a bright T2 weighted, bright T2 mass here in the right paraspinal region. And this is the axial post-contrast. Again, it's not the most ideal sequence, but nonetheless, you see some enhancement there. Then the patient was subsequently called back for dedicated views. So you have a coronal T2 weighted image of the spine. You can see that there's this nice T2 image, T2 lesion here, fairly circumscribed with some internal homogeneous hypo-intense areas. And on post-contrast imaging, those areas show enhancement. So take these images in and then be prepared for the question here. So what is the question? What is the diagnosis of this incidental lesion? Do you think that it's an intraosseous hemangioma? Do you think that it is a neurofibroma, C, schwannoma, or D, metastasis? So now you have to answer the questions here. So pick whatever option you feel is right: neurofibroma, schwannoma, metastasis, or intraosseous hemangioma. So neurofibroma and schwannoma, I'm getting both the answers. Ram Kumar says pseudomeningocele. That is also a good thought, Ram. It's something which you should think in a patient who has had a previous traumatic history. But look at the post-contrast imaging in this case as well. So most of the answers are C. Mangesh, Samreen, Nilanjan, all of you are answering C. Amal is also going for C. So that's exactly what is the diagnosis in this case. It's a schwannoma. So the reason why I brought up this case is to discuss a very interesting histopathologic feature of schwannomas, which leads to this imaging appearance. So remember that schwannomas are benign tumors. They can be seen in neurofibromatosis type 2, and they usually occur because of the abnormalities with the protein, which is called as Merlin, or which is also called as schwannomin. So it's an encapsulated tumor, but remember that larger tumors can have biphasic cellular morphology. So what does that mean is that the tumor is composed of Antony A cells, which are the central, more compact hypercellular areas, and they also have Antony B cells, which are the myxoid hypocellular area. And that gives this lesion this classical appearance on T2 weighted imaging, which is called as a target sign. So why it's called as target sign is because in the center you have this dark or slightly darker area on T2, and peripherally you can have a brighter area on T2. It's because of the Antony A and Antony B signs. If these lesions are located somewhere else, slightly towards the periphery into the extremity where you see a bulk of muscles and those kinds of soft tissues, you can have fascicular signs, split fat sign. Everything is because the lesion is very well encapsulated. So Anil Kumar has said target, perfect. So that's a target sign, and the reason why it happens is because of these two different different types of cellular morphologies. But remember that smaller schwannomas may not have this degree of differentiation, and they may not have the typical target sign appearance. So the next case on this list is a young female who is in her 20s, and she's being followed up with ultrasound for a prior history of right ovarian low-grade endometrioid cancer. So remember, endometrioid cancers are something which can be seen in the setting of patients who have endometriomas. So if you're following up somebody with endometriomas with serial ultrasounds, if you notice something new is happening in those endometriomas, you see new papillary projections, that is when you start to investigate further, do CA-125 and try to see if an MR would be helpful, because they may actually have these endometrioid cancers. They are low-grade cancers, but again, they are malignancies. So this patient was being followed up with ultrasound. The CA-125 levels were normal. They never went back after surgery. But remember, endometrioid cancers may not always have elevated CA-125. But nonetheless, we noticed a new segment 3 liver lesion on ultrasound. Let's see how the lesion looks like. Axial CCT image from the most recent CT shows this small segment 3 lesion. This CT was done because you can see that on ultrasound, there was this new small hypoechoic lesion in the liver. So lesion is hypoechoic, so it doesn't have typical features of a hemangioma, which would be expected as one of the benign lesions. And on CT, you definitely see that the lesion has arterial hyperenhancement, which is almost like peripheral discrete. So now these features don't go hand in hand. Like you would have thought that, okay, is it hemangioma based on CT? But it does not have typical features of hemangioma. So we went back, looked at patients' previous records, and found that there was a CT from 2016, which was performed at the time of staging. So look at how big you can see this large deposit posterior to the liver capsule. So the patient had quite a bit of peritoneal disease at that time, but there was no liver lesion. So now, based on these findings, what describes the next best step? Remember that the patient's CA-125 was elevated at the time of surgery. It went down after surgery and never got elevated after that. But now there is a new liver lesion in a female who is in her 20s. The lesion shows hyperenhancement on CT scan. So what will be the next steps? A, it is just a hemangioma, no follow-up required. B, it looks like a metastasis, you have to biopsy. C, PET CT, or D, just do an MR with hepatocellular contrast agent. So what would be your answer? So I can already see answers here. Eda, Anil Kumar, and Amal, Nilanjan, Selda, everyone is going for MR. That's an excellent choice. So the reason why I brought up this case is because of the fact that you have to put the entire clinical picture into one box before making any call. Although you may feel that this is a metastasis, remember that her CA-125 was elevated, so the tumor was probably going to cause CA-125 elevation. And the other thing is she is a young female, so she may have other benign lesions which need characterization with MR before sticking a needle inside. So with that, let's go into the answer and the explanation or what it looks like on the hepatocellular MRI. The reason why not PET CT is because, again, this was just a low-grade endometrioid cancer. It may not be picked up on PET CT. That's why. So we ordered the MR, the patient got an MR. So you can see that this is the ultrasound which we saw, this is the CT, and this is the T2 image. So I'm not sure if your screens are darker, it may be hard to pick up, but I can almost imagine that the lesion shows these central bright areas on T2 weighted image. So that is how the lesion looks like on T2. Then we have the axial arterial phase, the portal venous phase. So the lesion definitely shows enhancement, but it's not like one of those typical hyper-enhancing areas on hemangioma, but nonetheless, it does show enhancement. And the key sequence here will be your hepatocellular phase or the 20 minutes delayed phase. What is happening in this case, pay attention to the asterisk. What is happening in this case is the periphery of the lesion retains some contrast, but in the center, you will see that there is an area where the hepatocellular contrast is not retained. So remember, these hepatocellular contrast agents, they are used in cases where you have to decide whether the lesion is of hepatocellular origin or not. And the predominant mode of excretion of those contrasts is through bile. So any lesion which does not have a typical hepatocellular architecture, it does not have bile ducts or it has deformed bile ducts, it is going to show you abnormalities on this phase. So in this case, you see that there is central non-enhancement and some hyperintense areas on T2s. So now with this, the next question, what describes the next best step? Do you think that it's A, liver cell adenoma? Do you think that it's B, FNH? C, it is still unclear, I want to biopsy? Or D, surgical resection? So just go in with your answers A, B, C, or D. Remember the T2, remember the hepatocellular phase and how it looked like on ultrasound. It will give you your answer. So the answer, Zelda has given answer as B. That's exactly what it turned out to be. It's an FNH, focal nodular hyperplasia. So FNH versus adenoma is something in which hepatocellular contrast can be a very helpful tool. But remember, inflammatory adenomas may not have typical features of adenomas, and it becomes difficult to distinguish FNH from adenoma in that case. But what's happening here is that central scar, or whatever it was called as before, it's basically the hallmark of these FNHs. Now let's look at why it happens. Focal nodular hyperplasias, this is just a gross pathology which I have borrowed from Pathology Outline. So if anyone out there is not using that resource, please go to check that resource. It's amazing. I have used it throughout my fellowship and use it even now because it gives me an idea of what goes behind in pathology. They have beautiful gross specimens as well as histological images, and there's just a brief of the lesion morphology and etiopathogenesis. So this is just a cut section of an FNH. So all the white tan area you see in the center is an area which is fibrosis. So the key point is that here you can see all of this cellular proliferation, but at the center you have this fibrosis. So that appears bright on T2, and that is the area which does not retain Primo-West on the delayed phase because it does not have bile ducts. So now it's common in young adults, female more commonly, usually less than 5 centimeters, solitary, but can be multifocal. In this case, it was solitary, often subcapsular. This was a subcapsular lesion, and they are usually asymptomatic. Surgical consult is recommended only if you feel that the patient is symptomatic. Those are the cases which go to symptomatic assessment and to a surgeon. But remember, these imaging features will be seen only in about 80% of cases when the FNH is classic. There are non-classic varieties which are described in literature, like telangiectatic, mixed hypoplastic adenomatous, FNH with atypia, and steatohepatosis. So the idea here is that use your imaging as much as possible to see if you can diagnose it confidently, but if not, you may have to stick in a needle anyways. So all the atypical or non-classic lesions will not follow the typical imaging morphologies. Those are the cases when you will have to do biopsy. This is another nice graphic from the resource stated here. You see that there's this nice fibrovascular center in these FNHs, and it develops fibrosis. It is fed by a vessel which causes hyperenhancement. And then what happens is that there is a lot of ductular proliferation and hepatocyte proliferation at the periphery, which in self retains contrast, which you can see on the Primo-West image, but the center washes out because there is no bile ducts here. So now this, for whoever is starting to use liver MR as one of the recent things, if they're into their fellowship, they're into their residency, remember to check out this amazing article, which gives really nice schematic diagrams of multiple liver lesions, how they look like on different MR imaging. Let's go to the next case. A male in 60s comes in with abdominal pain, hematuria in the past, which was transient. The patient is diagnosed with a condition. I'm not going to disclose it right now. And the patient is on immunotherapy for that condition. The patient developed new headaches, so an MRI was performed. So this is just a magnified axial T2 image. You can see that this is an axial section at the level of ventricles. There is a small intraventricular mass in this MRI examination. And this was new. It was not seen on the previous examination. And just to show you what the rest of the things looks like, this is just an axial maximum intensity projection of chest in lung window. You can see that there are multiple lung lesions scattered in the lung. So there are these two images. Take those images in and answer the next question. What is the most likely diagnosis? A, patient has neurofibromatosis. B, it's rheumatoid arthritis with lung nodules. These are all metastases. And D, the patient has tuberous sclerosis. So just type in your answers A, B, C, or D. So I can already see Anil Kumar, Selda are saying as metastases. Then Shahita, sorry if I'm pronouncing it wrong, but Shahita is saying that it can be B, rheumatoid arthritis. Abdul is saying D, tuberous sclerosis, and Amal is also saying C. And Selda has given away the answer here, RCC MET. So I'll come back to that in a second here. But again, this was RCC MET. So excellent job. So let me tell you why this is so typical in this case. So the final diagnosis here is obviously RCC with choroid plexus mets. So choroid plexus metastasis is not very common entity, but whenever that happens, it is usually going to be RCC or lung cancer as a primary causing mets in the choroid plexus. So remember, the patient's history was that previous history of hematuria, upper abdominal pain, and patient is on immunotherapy. So that fits the bill for RCC or metastatic RCC. Again, for lung as well, there's going to be immunotherapy, but it looks like the patient had other clinical factors pointing toward RCC. Whenever you see choroid mets in children, it can be Wilms tumor, neuroblastoma, or retinoblastoma going there. So just briefly touching upon types of RCCs, all we know are typical clear cell and papillary type, which can be seen pretty commonly, but there are other varieties which we should be aware of. Chromophobe variety, which is usually, it is similar to oncocytomas and it has the best prognosis. The worst prognosis is seen with collecting duct RCC, which is usually seen with younger patients. And then medullary carcinoma, as we are all aware that many of the areas in this world are endemic for sickle cell disease. In those cases, the variety of renal cell cancer, which most commonly occurs in those individuals, is medullary carcinoma, again, has a very bad prognosis. Least commonly, you can also see sarcoma or dedifferentiation. And then DDs, remember, for the intracranial lesion, DDs can be intraventricular meningioma, central neurocytoma, cerebroendyma, or a colloid cyst. So if you have somebody belonging to these hereditary RCC syndromes, VHL, tuberous sclerosis, Bourtois-Dubé, or Lynch syndrome, you may see multiple RCCs and they may metastasize. So this is the axial MR of the same patient. You can see that there's a large exophytic mass in the right kidney, which is enhancing with central necrosis in keeping with RCC. And this is an image which I have never seen anything like this before. So this is a coronal MR at the same time, and it was a MIP in arterial phase. So you can definitely see the thoracic and abdominal aorta with iliac bifurcation, that's the renal mass. And these are the lungs which are studded with metastases in this individual. So the next case is again on the same renal spectrum. So you have these images here. On the left side axial, T2 fat suppressed, then you have T1 pre-contrast, and then you have T1 water, lava, which is just a brand specific sequence name, but water sequence, why it is called water sequence, because this was acquired using Dixon technique. For those who don't know or not using Dixon, please go there, explore it, it's a game changer. And then this is a actual T1 in portal venous phase. So you have your pre-contrast T1, your T2, as well as arterial and portal venous phase, looking at an incidental right renal mass. In terms of description, let me give away the descriptors which I would use for this lesion. It's a 1.3 centimeter cystic mass, and it does not have significant wall thickening, but it has multiple, more than or equal to 4 smooth, thin septa, which measure less than 2 millimeter in size. All of these numbers are very important. Pay attention to them. And on arterial and portal venous phase, they show enhancement, but most important thing, there are no convex protrusion. This was incidentally discovered, and then it was being under surveillance in a patient who is in her late 60s, and then she has had a previous rectal cancer in 2012, and she also had a known aortic dissection. So remember, more than 4 septa, thickness is less than equal to 2 millimeters, and it enhances, and the lesion is 1.3 centimeter in size. So what is the Bosniak category for this lesion? Do you think it is 1? Don't worry about anything. B, Bosniak 2F, C, Bosniak 4, or D, Bosniak 2. So just type in your answers as A, B, C, or D. Remember, those numbers are the key here. So Zelda is saying 2F. I agree with that. That's exactly where it is. Then Stuti, Anil, everyone is going for 2, that is B, that is Bosniak 2F. So this is indeed a Bosniak 2F lesion. So remember, these Bosniak categories are based on the most recent updated version, which was published in 2019. So for those of you who haven't read that here or haven't been aware of that, make sure you go and check that out. I also have a link for that in the next slide. So let's look at some of these important features in Bosniak categories. So this is the source of the article where you will find all the information. This graphic belongs there. So the most important things to remember are anytime, whenever you, like this is the diagram which I'm going to show you in a little bit detail. So this portion on the right side of that circle, so this is just a cyst, right? Like this is a schematic for a cyst. So anything on the right side is going to be Bosniak 4 features, and anything on the left is going to be Bosniak 3 features, and these are nothing but convex protrusions. So whenever this is a cyst wall and whenever you start to see something bulging from that wall, it's called as a convex protrusion. It can be from a cyst wall or it can also be on a septa. Irrespective of its size, if it has convex margins with the cyst wall, like in this case, it is going to be a Bosniak 4. But if it's a small convex protrusion and it just has these obtuse margins, it can fall in this category of Bosniak 3. But whenever it's a convex protrusion with your acute angles, it is going to be a Bosniak 4. That's basically the most important take-home point. Otherwise, obviously, whenever I'm reviewing these cases, I always go back to the chart whenever I'm in doubt. But that helps a lot. Remember to check this article; it is amazing. The goal is to downgrade or undercall so many of the so-called complex renal lesions which were followed up before. Then this is the same patient who went on for follow-up, and at 3 years, it actually developed a large, you can see convex protrusion here now, and again, another convex protrusion. So now this will be a Bosniak 4, which will be highly suspicious for a RCC. Round 3, that's the last round here, challenging cases. Remember, you do not rise to the level if you do not rise to the level of your goals. You fall to the level of your systems. And then you always figure out something and then you become successful after that. So this case is a bit of a difficult one. You have to use a lot of multi-modality approach here. So I will start with the pelvic MR. So this is an axial T1 weighted image. Remember, I'm again labeling them as water here. It's because it's a Dixon technique which we use. So axial post-contrast T1 in arterial phase and then venous phase. So there is a left adnexal mass, and the left adnexal mass eventually shows that it retains contrast. So on this phase, it is obviously enhancing less than the myometrium, but you do start to see some enhancement. And then here, the myometrium also shows progressive enhancement, but the lesion also shows enhancement. So there is a left adnexal mass which has irregular solid component, and it shows enhancement. The background of the patient is that she is a perimenopausal woman with a previous history of left skin cancer, and it was metastatic to left axillary lymph nodes. 3 years later, she presented with this adnexal mass. So naturally, let's go back to the ultrasound, because that is how she's going to first, she'll be assessed first with ultrasound. So I'm sure that all the viewers here have attended amazing session on ORADs by Dr. Skandan. So just reiterating some of those facts and how to use dynamic sonographic assessment whenever in doubt. So this is just a transvaginal ultrasound. You can see that the image is annotated. There is this left adnexal mass, which is irregular and solid. It shows vascularity on color Doppler. And then this appears to be the native ovarian tissue. These two images are the most important here. Always make sure that you use your dynamic assessment. So what is happening in this case is that this is just normal static image when the transducer is in the vagina. But in this case, what we are trying to do is we are trying to push with the transducer and trying to see if the ovary separates from the mass, because that would make sure that the lesion is not ovarian in origin. If the lesion and the ovary stick together, even when you're pushing the transducer, it means that the lesion is attached to ovary or arising from the ovary. So that's a very important tool which you can use when you're performing these pelvic ultrasounds. So remember, so now you have left ovarian irregular mass. It's a solid irregular mass. It is arising from the left ovary, and it is enhancing on post-contrast MR. So what is the diagnosis here? Is it on the fibrothecoma spectrum, given the patient's perimenopausal status? Is it a dysgerminoma? Is it a metastasis, or is it a Brenner tumor? So it's a bit of a kind of an interesting outcome for this patient. But anyway, so try your best to answer this question, typing A, B, C, or D. So what do you think is the answer for this case? Okay, so I'm seeing answers of fibrothecoma, dysgerminoma. There seems to be a bit of a spread here. Then I'm also seeing Brenner tumor. So yeah, so I mean, Mangesh, Anil Kumar, Amal, and Ram Kumar Verma, Satim, and Nam is also giving answer of metastasis. So all of these answers, again, like it's going to be fairly challenging to diagnose it on imaging once in a while when you don't have the complete imaging set. But the key point here is that use your ORADs. Make sure that you assess the lesion and provide a risk of malignancy. That is what these ORADs or all the RADs are about. You have to predict what is the likelihood of malignancy. So in this case, definitely this patient needs further imaging and a surgical consult to see if this lesion can be excised. In that case, let's go ahead and see what was the final, because that's what we did. We said that this is ORADS 5, the patient needs a surgical consult. And the patient went ahead, got it excised, and final what it was a Merkel cell tumor metastases into the ovary. So Merkel cell tumors are very kind of elusive tumors. They are a form of skin cancer. Remember that was in one of the history of this patient. So these are a form of skin cancers. They usually present with lymph nodal metastases, but solid organ involvement is also seen. And these are very aggressive in nature, and they can cause metastases many years out of the initial presentation. So if you had to use IOTA simple rules to classify this lesion, so if you are not aware of that, there are 5 B rules and 5 M rules. So the B rules are basically all the things which can be seen usually in benign lesions, and the M rules are usually the things which can be seen in malignant lesion. So if you have one or more M rule but no B rule, the lesion can be classified as being probably malignant lesion. But if you have more than one or more B rules and no M rules, then you can fairly confidently classify the lesion as a benign lesion. So going back to our first case, that lesion was benign because that lesion had acoustic shadows, and it also had echogenic components, but it did not have any M rules. So with this, you will classify that as irregular solid tumor and no B rules. So it was a M lesion or malignant lesion. And remember to use dynamic assessment to classify the lesion. With this, let's move on to the next case. So now I have 2 liver cases, which are just towards the end of this session today. This is the first lesion. I'm not sure how good you are seeing this on your screen. I just have a lot of bright light coming from the background. But you do see that this is an axial MR. T2 mirror image and T1 pre-contrast T1 out of phase image. So there is an area in the liver which looks like there's an ill-defined bright T2 spot, and on pre-contrast T1 out of phase image, you see an India ink artifact. So in and out of phase imaging is something which is commonly used in body MRs, especially for livers, adrenal lesions, as well as in the pelvis, where you have to quantify if the lesion can have intracellular fat or microscopic fat. I have also seen this being used for definitely assessing any hemangiomas in the bone. I'm not sure what is everyone else's experience with that. But her history was that the patient had a recurrent ovarian carcinosarcoma with a sarcomatous transformation, and she was not doing well at this time. But incidentally, they also discovered a new liver lesion which was not present before. So now this is the contrast, the unenhanced CT of the same patient. You see that there's a large mass in the liver. It has a more focal hypodense area, which is these things in the MR. And then this is the CT section, axial CT section at the level of the umbilicus, which shows a large metastatic deposit, which is also causing the patient bowel obstruction. So the question is, what is the diagnosis? Do you think that this is just focal fat in the liver, A, B, extramedullary hepatopoiesis, C, metastasis, or D, it is an angiomyolipoma? So just type in your answers. What do you think? Is it A, B, C, or D? So remember that it showed India ink artifact on out of phase. The patient has a history of carcinosarcoma with some kind of sarcomatous transformation. It was an incidental pickup. And then those are the CT images here. So focal fat, I'm seeing an answer of focal fat and focal fat. Then Raul is answering C, metastasis. So it looks like most of the answers are going towards E, and some answers like Mangesh or Raul going towards metastasis. So remember that although it can be a presentation of focal fat and it lands in that space where you would usually see focal fat around the gallbladder fossa, her history is quite interesting because she had a recurrent ovarian carcinosarcoma with sarcomatous transformation. And in her case, that sarcomatous transformation was actually containing a liposarcoma component. So this was just a metastasis. So remember that the metastasis can also dedifferentiate. And that's something which I have come to know after working in here in Cancer Center. Like even if the primary tumor never had liposarcomatous differentiation, the metastasis or the recurrence can have it because it is just dedifferentiating. So this was a very, very interesting case, but just to bring up two things for discussion. One, remember to use your in and out of phase imaging, and two, think out of the box whenever there is something which is atypical or uncommon, which is happening in certain individuals. So lipomatous transformation or liposarcomatous transformation can be seen in metastases, as we discussed right now. But remember that lesions containing only fat can also have typical benign and malignant lesions. Remember lipomas, xanthomas, packing material, if omentum was used. Then primary liposarcomas or metastatic liposarcomas can have fat, but at the same time, if you have fat and soft tissue component, like what is happening in this case, it was metastatic liposarcoma, but it can also have other lesions like adenomas, adrenal less tumor, angiolipomas, teratomas, hepatocellular carcinomas. All of them can have it. Even extramedullary hematopoiesis can have intracellular fat, which will show in the ink artifact. So just a very interesting case and some interesting points to remember, and remember to use your in and out of phase. Last case of today's rounds, very interesting patient with completely incidental discovery. Patient went in with just an upper abdominal pain. She was in her late 70s. The ultrasound showed that there was a large left lobe of liver mass. CA 19.9 was 179, AFP was 6.4. And then because of this, they thought that, okay, why not let's go back and do testing for HBV, HCV to see if the patient has any evidence of cirrhosis, but it came back as negative. So now you have your axial arterial phase T1, 3-minute delay, and your out of phase image. So it's a definitely hyper enhancing lesion, which is predominantly involving the left lobe, but also going into the segment 4. And then it shows large areas of washout on delayed phase. And then there are also other multifocal areas. For example, this lesion here, which is on the other side of the middle hepatic vein, going into the segment 8, and it shows this large India ink artifact on out of phase imaging. The same is happening to some of the areas here on the left lobe. So keep in mind about these findings, and let's see what are the options here. So what is your diagnosis? Is it just asymmetric fat infiltration? Do you think that it's an angiosarcoma B? C, liver cell adenoma, large liver cell adenoma, and D, is it a metastasis? So what are your options here? And if you feel that none of these apply, then you can just not applicable. It's something which you have to think about. So I'm seeing answers as angiosarcoma, liver cell adenoma, metastasis, asymmetric fat. Remember, if you don't agree with the options, you also have the options of saying that I don't agree with it, or there are no options to choose from. But I can see that many of you are going for angiosarcoma, which is a good choice. Nice. Okay, and obviously it's not going to be a metastasis, it's a large lesion in the liver. So again, this was it was a dummy question, or whatever to say as. So this was none of these. The answer here is that it was a well-differentiated hepatocellular carcinoma with a background of fibrosis and cirrhosis. This is something which can happen with something which is called a ceratomimetic type of HCC. So if you don't know about this subtype, you can try to go and read more about it. It's something which is very, very typical. When you see it once, you will always remember it. So ceratomimetic HCCs are usually the large HCCs which involve the entire lobe, go to multiple segments. You will see a large area. But when you do a biopsy, the biopsy specimen or the final histopathology, they will read that they see well-differentiated HCC, but there is lots of background of cirrhosis and fibrosis, and you will have these tiny rests of HCC everywhere. And that subtype is called a ceratomimetic type. Even though the patient does not have cirrhosis, it mimics an appearance of cirrhosis, and patient has no background history of HCV or HBV. So just a quick thing here to remember: whenever you have these HCCs, go back to brush up your LIRADs. And whenever you're brushing those LIRADs, it's always important to know, why do these lesions show arterial hyperenhancement? So this is absolute gold. If you haven't used this freely available LIRADs manual on ACR website, please go and download it right now. It's amazing. It will clear out so many concepts. So in hepatocarcinogenesis, what happens is that there is a spectrum of lesions. You start from your cirrhotic nodules, which grow into low-grade dysplasia, into high-grade dysplasia, then early HCC, small progress HCC, and large progress HCC. So now what happens is you see these small discs of red color. Those are all capillaries or neoangiogenesis. So in early stages, you will see that there is orderly growth. but as the lesions grows, you will see neoangiogenesis, and that is something which causes you to have arterial hyperenhancement. And then whenever there is arterial hyperenhancement, that is when you pick up most of these lesions. But with large progressed HCCs, there is a transcapsular infiltration and you lose the appearance of arterial hyperenhancement. So remember, large HCCs may not have typical arterial hyperenhancement as you would expect in some small progressed HCCs. So just something to remember in cases of HCCs, to go back and brush up your LIRADs, and remember to use only in cases where there is history of cirrhosis or there is cirrhosis. Don't use it in patients who don't have cirrhosis. So a question here is that can we call it as multicentric HCC? So remember, it is something which is for multicentric HCC, the histopathologists may call it as multicentric HCC, but on imaging here, all you see is that the entire left lobe is involved by a large mass. You don't see discrete lesions here and there. Obviously, there are multiple abnormal foci in the right lobe. You can call it like that. You will see that there's a large mass in the left lobe infiltrating into the segment 4, concerning for a large HCC, but there are other multiple foci of abnormality which could either represent metastasis or multifocal involvement. That is how I usually put it. But in the end, the prognosis is very poor and the patient needs to be staged, and they have to start on chemotherapy. There is no surgical outcome in these individuals, as it is not small. And given the size, it may also be challenging to perform any sorts of ablations. They may perform TACE or TARE, depending on the availability of resources. Okay, so that was the end of today's session. So thank you all for joining and participating in the quiz. I just thought of putting together some interesting body MR cases and putting a quiz together. So with that, I'm going to end my screen share and over to
you. Thank you, Ameya, for those interesting cases. I'm sure our viewers must have learned quite a new point. So most of your cases were, along with the typical features, there were quite a few atypical ones. Okay, just let me switch on my camera. Okay, thank you. I think for some reason it's still showing up your screen. Okay, anyways, thank you everyone for joining us for today's live session. And we do these every Saturday at 8 p.m. India time and 10:30 a.m. Eastern time. So if you're new here, subscribe to the channel and turn on notifications so that you get an update whenever we are online. And finally, do let us know your feedback about the lecture. You'll get an email for those who have registered online. You'll get an email. Let us know how we did. And for those who have not registered, you can let us know in the comment section. Leave a thumbs up to the video and leave a comment below. Thank you, everyone, and see you guys in the next video. Bye-bye.